Today I'll be presenting our audit evaluating frailty assessment in patients over the age of 60 undergoing operative management on the orthopaedic trauma list at Tallaght Hospital. Our audit was prompted by awareness of national standards from the Centre for Perioperative Care, the British Orthopaedic Association Standards for Trauma, and the National Hip Fracture Database. Together they all recommend patients over the age of 60 years old undergo formal pre-op frailty and delirium risk assessments using validated tools such as the Clinical Frailty Scale and 4AT tool. This information should be used to guide perioperative and multidisciplinary planning. Despite this guidance, frailty and delirium risk assessment is often inconsistently documented or not incorporated into perioperative decision-making. Tallaght is the National Centre for Pelvic and Acetabular Fracture Management in Ireland. Therefore, a significant number of patients on the ortho-trauma list present with hip fractures and are over the age of 60, physiologically vulnerable and at high risk of adverse perioperative outcomes. Frailty is a particularly useful marker to assess in this cohort as it predicts a variety of post-operative complications including delirium, prolonged admission and loss of independence in terms of functional status. We performed a prospective observational audit of 26 consecutive hip fracture patients undergoing emergency operative management in Tallaght. The aim was to assess whether pre-op frailty and delirium risk assessments were being performed with validated tools like the CFS scale and the 4AT, whether they were being documented reliably, and whether patients were receiving timely orthogeriatric input, ideally within 72 hours of admission. The results show a mixed picture. Overall, appropriate pre-op assessment is happening in the majority of cases, with 69% of patients having a CFS score documented within 24 hours of admission, and 65% documented preoperatively. The CFS distribution had a median score of 4, with 8 patients scoring 5 or above, highlighting a clinically important burden of frailty in this cohort. Orthogeriatric review within 72 hours and 4AT completion were both high at 88%. However, 17% of 4AT scores were first documented post-operatively, meaning a lack of pre-anaesthetic baseline for later comparison. Additionally, frailty and delirium risk were not documented in the anaesthetic record in any case, suggesting that frailty data may be collected by the wider team but isn't visible during the time of anaesthetic planning and perioperative discussions. Outcome data reinforces the relevance of perioperative frailty and delirium assessment in orthogeriatric patients. 35% of patients developed post-op delirium, 46% had some form of post-op complication, and 19% required ICU admission. The median length of hospital stay was 22 days. These are only preliminary descriptive results, but they emphasise that this is a high-risk patient group where frailty-informed planning is clinically relevant to minimise post-op complications and extended hospital stay. We conclude that whilst frailty assessment is frequently performed appropriately, it's not consistently translated into anaesthetic documentation, nor visible at the point of perioperative decision-making. Our next audit cycle will therefore focus on systems-level interventions such as introduction of a structured frailty handover prompt during the morning ortho trauma huddle, including CFS score, 4AT, baseline cognition and treatment escalation status, and delivery of targeted multidisciplinary staff education before re-audit to assess improvement in compliance and patient-centred outcomes.